There is a paradox written into the human body that defies evolutionary logic. We are the most intelligent species on Earth, capable of medicine, engineering, space travel, yet we possess one of the most dangerous reproductive systems in the animal kingdom. A healthy elephant can give birth standing, her calf dropping safely to the ground and standing within an hour. Dolphins navigate birth underwater with practiced ease. Even our closest relatives, chimpanzees and gorillas, deliver their young with relative simplicity, often in solitude, without complication. But human mothers face odds no other mammal endures. For most of our 300,000-year existence as Homo sapiens, pregnancy and childbirth were leading causes of death for women of reproductive age. Why? What happened in our evolutionary journey that made creating life so perilous? The answer lies not in a single change, but in a cascade of adaptations, each solving a survival problem, while creating a reproductive crisis. Over 6 million years, our ancestors made evolutionary compromises that transformed us from tree-dwelling primates into upright, big-brained humans. We gained intelligence, language, and culture. But our mothers paid the price. Tonight, we'll explore the anatomy, biology, and deep history of why human pregnancy became more dangerous than any other species. This is a journey through time, through bone and blood, through the impossible trade-offs that made us human. To understand why human pregnancy became dangerous, we must first see what safety looks like across the mammalian world. Birth in the animal kingdom is generally straightforward, not painless, not without effort, but rarely fatal. A mare gives birth in open pastures, and within minutes her foal struggles to its feet, legs trembling but functional. Within hours, it runs. Dolphins deliver their calves tail first in the ocean, an adaptation that prevents drowning, and the newborn swims immediately to the surface for its first breath. A house cat can deliver a litter of kittens in a quiet corner, each rival taking minutes. Her body designed for the process with minimal intervention. Even among large mammals, elephants, giraffes, rhinoceroses' birth follows a predictable pattern: contractions, delivery, a brief recovery, and a mobile infant, the biological norm, shaped by hundreds of millions of years of mammalian evolution, is elegant. The birth canal is proportional to the size of the offspring's head. The pathway is relatively straight. The infant emerges facing forward or sideways, allowing the mother to assist with her own body-licking away membranes, clearing airways, severing the umbilical cord with her teeth if necessary. Maternal mortality from the act of birth itself is uncommon in wild populations. When mammal mothers die around the time of giving birth, it's typically due to predation while vulnerable, starvation during the metabolic demands of late pregnancy, or infections not from the mechanical act of delivery. Studies of our closest living relatives reveal this baseline clearly. Chimpanzees, with whom we share approximately 98.8% of our DNA, give birth in relative solitude. A pregnant chimpanzee in the wild will often separate from her group as labor begins, seeking privacy in the trees. The birth itself takes hours, not days. The infant emerges facing forward, allowing the mother to guide it, clear its airways, and immediately bring it to her chest. The baby chimp can grasp its mother's fur within minutes, clinging as she moves. Gorillas follow similar patterns. Orangutans, despite their solitary nature, navigate birth without requiring assistance. Observations of primate births in the wild show that complications exist, but are rare exceptions, not expected outcomes. Comparative anatomy studies have mapped the pelvic structures of dozens of mammalian species. The pattern is consistent. The pelvic opening, the bony ring through which the infant must pass, is sized to accommodate the infant's head and shoulders with some margin for variation. There's evolutionary pressure to make this fit as efficient as possible. Too large a pelvis wastes energy and resources building unnecessary bone. Too small a pelvis kills mothers and infants, removing those genes from the population. Natural selection has calibrated this dimension with precision across species. Veterinary medicine provides data here as well. Domestic animals occasionally experience birth complications dystocia, the clinical term for difficult labor, but these are often artifacts of human selective breeding. Bulldogs, bred for large heads and compact bodies, frequently require cesarean sections. Certain cattle breeds, bred for meat production with disproportionately large calves, face similar issues. But these are human-created problems. Wild populations of the same species give birth successfully without intervention. So we must ask, is human birth truly uniquely dangerous? Or are we simply the only species documenting every death, every complication, every near miss? Perhaps our perception is skewed by record keeping, by the fact that humans write down what other animals cannot report. The evidence suggests otherwise. When anthropologists compare maternal mortality rates in human populations, without modern medical intervention to any other primate population, the difference is stark. Historical human maternal mortality, the death of a mother during pregnancy, birth, or the immediate postpartum period ranged from 1 to 2% per birth. This figure might seem small until you consider that women in these populations often experienced 6, 8, 10 pregnancies over a lifetime. The cumulative risk becomes staggering. A woman facing 10 births had a 10 to 20% chance of dying from pregnancy-related causes over her reproductive lifetime. No other primate faces odds remotely comparable. The archaeological record supports this as well. Skeletal remains of young adult females from pre-modern populations often show pelvic damage, stress markers consistent with repeated childbirth, and ages of death clustering in the reproductive years. Burial sites across cultures and millennia contain the remains of mothers buried with infants, both having died together at tragedies so common it shaped funeral customs worldwide. For most mammals, birth is physically demanding, instinctually driven, and generally survivable. The female body is built for it, refined by selection pressures over geological time. The process works because all the components, pelvic dimensions, infant size, canal geometry, maternal physiology are calibrated to each other. Human birth stands as a statistical and anatomical outlier. Something in our evolutionary history diverged from this mammalian blueprint. The calibration broke, and the question that emerges from this baseline is clear. What changed? The answer begins 6 million years ago, not with pregnancy, but with the decision if evolution can be said to make decisions to stand upright. The danger began not with pregnancy, but with a single evolutionary shift that redefined what it meant to be human, walking on two legs. 6 million years ago, in the forests and savannas of East Africa, the common ancestor of humans and chimpanzees lived in the trees and on the ground, moving primarily on four limbs. The world was changing. Climate fluctuations were transforming dense forests into fragmented woodlands and open grasslands. The environment that favored tree dwelling was fragmenting, and survival pressures began to favor a different way of moving. Between 6 and 4 million years ago, early hominins, members of the human lineage after the split from chimpanzees, began spending more time upright. Exactly why this happened remains one of the great debates in paleoanthropology. Some researchers argue that standing upright allowed early hominins to see over tall grasses, spotting predators, and locating food sources across open landscapes. Others suggest that freeing the hands enabled carrying food, tools, infants, which improved survival and reproductive success. Still others point to thermoregulation. Standing upright reduces the surface area exposed to the brutal equatorial sun and elevates the body into cooler air currents above the ground. Whatever the initial cause, bipedalism, walking on two legs as the primary mode of locomotion, became the defining characteristic of our lineage. The fossil record traces this transformation through skeletal changes. Ardipithecus ramidus, living for 0.4 million years ago, shows a mix of tree-climbing adaptations and features suggesting some upright walking. Australopithecus afarensis, the species to which the famous Lucy's skeleton belongs, walked upright 3.2 million years ago. Her skeleton reveals the fundamental shift: a repositioned spine, an S-curve to balance weight over the hips, foot arches to absorb shock, and critically, a transformed pelvis. The pelvis is the keystone of bipedalism. In quadrupedal mammals, the pelvis is elongated and oriented horizontally, providing a large, stable platform for the abdominal organs and a wide, straightforward birth canal. The iliac blades, the large, flat bones that form the sides of the pelvis, flare outward, supporting powerful locomotion muscles. Bipedalism required a radical redesign. To walk efficiently on two legs, the pelvis had to shorten and reorient vertically. The iliac blades rotated inward, creating a bowl-like structure to support abdominal organs against gravity's downward pull. The entire pelvic structure narrowed. This narrowing was not optional. It was biomechanically necessary. A wide, quadrupedal pelvis would make upright walking inefficient and unstable, wasting energy with every step. Natural selection strongly favored a narrow pelvis for efficient bipedalism. But here's the problem. A narrower pelvis means a narrower birth canal. Studies comparing pelvic dimensions across primates illustrate this starkly. A chimpanzee pelvis, designed for quadrupedal knuckle walking with some upright posture, has a birth canal that is relatively spacious compared to the size of a newborn chimp's head. The fit is manageable. A human pelvis, reshaped for bipedalism, presents a much tighter passage. The pelvic inlet, the upper opening of the birth canal, and the pelvic outlet, the lower opening, are narrower in all dimensions. This created the first evolutionary compromise in the chain that leads to dangerous human birth. Mobility versus reproduction. The same skeletal structure that had to support efficient upright walking also had to allow offspring to pass through during birth. These two functions place opposing demands on pelvic architecture. Selection for better walking narrows the pelvis. Selection for successful birth widens it. The human pelvis exists in tension between these forces. Female pelvis structure shows this compromise clearly. Human sexual dimorphism, the physical differences between males and females, is pronounced in the pelvis. Women have, on average, wider pelvic inlets and outlets than men, a slightly different pelvic shape, and a broader sciatic notch. These differences emerge during puberty, preparing the female body for potential childbirth. Yet even the female pelvis, wider than the male, is still dramatically narrower than would be ideal for easy birth. It's a compromised structure, satisfying neither function perfectly. The evidence for this trade-off comes from biomechanical studies. Researchers have modeled what an optimal pelvis would look like for walking efficiency alone, narrower than even modern human males possess. They've also modeled an optimal pelvis for birth alone, significantly wider than modern human females possess. The actual human pelvis sits between these optima, a structure that walks well enough and births with enough success to have survived selection pressures. What is ideal for neither the consequences of this compromise extend beyond birth. Human hips and lower backs are prone to problems: pain, arthritis, herniated discs, because the bipedal spine and pelvis are evolutionary jury-rigged structures, not clean sheet designs. The S-curve of the spine balances the body, but concentrates stress on the lower vertebrae. The reoriented pelvis supports organs, but at the cost of structural strain. Modern humans inherit this ancient compromise with every step we take and every child we bear. The narrowing pelvis set in motion millions of years ago laid the foundation for every obstetric challenge that would follow. But narrowing the canal was only half of the equation. At the same time, on a separate evolutionary track, something else was happening. Our brains were growing. Asterisk, while the birth canal was shrinking to accommodate upright walking. The cargo it needed to deliver was growing at an unprecedented rate in the history of life on Earth. 2 million years ago, early members of the genus Homo emerged in Africa. Homo habilis, one of the earliest, possessed a cranial capacity of around 600 cubic centimeters larger than any Australopithecus, but still modest by modern standards. Within the span of less than 2 million years, brain size in our lineage exploded. Homo erectus, appearing around 1.9 million years ago, averaged 900 cubic centimeters. Archaic Homo sapiens, emerging around 300,000 years ago, reached 1,000 to 100 to 1,100 cubic centimeters. Modern humans today average around 1,350 cubic centimeters, with significant individual variation. This represents one of the fastest increases in brain size relative to body mass in the entire fossil record. The question of why has consumed researchers for decades. Brain tissue is metabolically expensive. The human brain, representing only about 2% of body weight, consumes approximately 20% of the body's resting metabolic energy. Growing and maintaining a large brain requires high-quality nutrition and carries significant costs. Evolution does not waste resources on expensive organs unless they provide substantial survival or reproductive advantages. Several interrelated factors likely drove brain expansion. Tool use is one hypothesis. The archaeological record shows increasingly sophisticated stone tools appearing alongside larger-brained hominins. Making and using tools requires spatial reasoning, planning, fine motor control, and the cognitive capacity to learn and teach techniques. Groups with better tool users accessed more food sources: meat from hunting, marrow from broken bones, tubers extracted from hard ground, which in turn provided the calories to support larger brains, creating a positive feedback loop. Social complexity offers another explanation. As hominin groups grew larger and social structures became more intricate, the cognitive demands increased. Navigating alliances, remembering individual relationships, anticipating others' intentions, coordinating group activities, all of these require significant cognitive processing. Researchers call this the social brain hypothesis. Brains grew large to manage complex social worlds. Language, appearing at some point in this timeline, would have accelerated this trend dramatically, adding layers of symbolic thought and cultural transmission. Ecological challenges also played a role, adapting to diverse and changing environments, migrating into new climates, exploiting different food sources, solving novel survival problems selects for cognitive flexibility and learning capacity. Hominins who could adapt behaviorally rather than waiting for slow genetic evolution had enormous advantages. Sexual selection may have contributed as well. If intelligence became a trait that influenced mate choice, if clever individuals were more attractive as partners, then runaway selection could have accelerated brain growth even beyond purely survival-based utility. Whatever the precise mix of factors, the result is clear. Hominin brains grew large, and they grew quickly. And here the second evolutionary compromise emerges. Larger brains require larger skulls. Infants must be born with heads big enough to house brains capable of rapid postnatal growth. And those heads must pass through the birth canal. The dimensions are stark. A newborn human infant's head circumference averages about 35 centimeters. The human pelvic inlet, even in females, measures roughly 13 centimeters at its widest diameter and 11 centimeters at its narrowest. The infant's head is significantly larger than the canal through which it must pass. The bones of the birth canal do not expand during labor. They are fixed. The infant's skull, however, has some flexibility. Human fetal skulls are not solid domes. They consist of several bony plates separated by fibrous sutures and soft spots called fontanelles. During birth, these plates can overlap slightly, compressing the skull into a more elongated shape, a process called molding. This compression is temporary. The skull rounds out again after birth, but molding can only reduce the diameter so much. Even with maximum compression, the fit is extraordinarily tight. Comparative data highlights how unusual this is. In chimpanzees, the infant's head is about 40% smaller relative to the mother's pelvic dimensions compared to humans. The chimp baby fits through more comfortably. In humans, The ratio is at the edge of biomechanical possibility. Studies using MRI and CT imaging to model human birth mechanics show that the infant's head passes through with millimeters to spare in some dimensions. There is almost no margin for error. This tight fit creates multiple dangers. If the infant's head is even slightly larger than average, a condition called macrosomia, often caused by gestational diabetes or genetic factors, the head may not fit through at all, causing obstructed labor. If the mother's pelvis is even slightly smaller than average, whether due to genetics, malnutrition during her own childhood affecting bone growth, or pelvic injury, the same obstruction occurs. Cephalopelvic disproportion, the medical term for a mismatch between head and pelvis, becomes a life-threatening emergency without intervention. The fossil record provides evidence of this squeeze. Researchers studying Homo erectus fossils, with brain sizes intermediate between earlier hominins and modern humans, can see the obstetric dilemma beginning. As cranial capacity increased in the archaeological record, researchers infer that birth difficulty must have increased as well. The pelvis could only widen so much without compromising bipedalism. The infant head could only shrink so much without compromising brain size. A physical impasse was emerging. Natural selection faced an impossible equation. Brains needed to be large for survival. Pelvises needed to be narrow for mobility, but infants needed to pass through. Evolution's solution was both brilliant and brutal. If the infant's head could not be made smaller, and the pelvis could not be made wider, then birth would have to happen earlier before the head grew too large. Faced with an infant head that increasingly could not fit through the birth canal, evolution arrived at a radical solution. Birth would occur before development was complete. Human infants are born in a state of neurological immaturity unparalleled in the primate world. At birth, a human baby's brain is only about 25 to 30% of its adult size. This is astonishingly underdeveloped compared to other primates. A newborn chimpanzee's brain is roughly 40 to 45% of adult size. More distantly related mammals show even greater maturity at birth. A guinea pig is born with a brain at 50% of adult size and can walk within hours. Human babies, in contrast, are helpless. They cannot hold up their own heads for weeks. They cannot sit unsupported for months. Walking takes a year or more. Vision is blurry and unfocused for weeks after birth. The ability to grasp objects intentionally develops over months. The infant cannot regulate its own body temperature effectively, cannot communicate beyond crying, cannot feed itself, cannot escape danger. Total, absolute dependence on caregivers is the human newborn. Condition: developmental biologists sometimes describe human infants as being born too early. If human gestation followed the pattern seen in other primates relative to brain development, pregnancy would last not 9 months, but 18 to 21 months. A human infant born after that duration would be neurologically comparable to other primate newborns, able to cling, visually aware, capable of some locomotion. But an 18-month-old human fetus would have a head far too large to pass through any pelvis, compatible with bipedal walking. The physical impossibility is absolute. So birth happens at 9 months, when the head is just barely small enough to fit barely and the rest of development happens. Externally, this creates what anthropologists call secondary altriciality. Altricial species are those born helpless and requiring intensive parental care. Think of naked, blind baby birds in a nest. Precocial species are born relatively mature and mobile. Think of a foal standing minutes after birth. Humans are neurologically altricial despite being primates, a typically more precocial order. Our altricality is secondary because it evolved not as the ancestral condition, but as a later adaptation to solve the obstetric dilemma. The evidence for this comes from comparative developmental timelines. Researchers tracking neurological milestones, myelination of nerve fibers, synaptic density, brain region maturation show that human infants are completing in the first year of life what other primates complete in the womb, the first 3 to 4 months after birth. Sometimes called the 4th trimester, represents a period of development that, in an ideal world without pelvic constraints, would occur inside the mother. The fetal skull structure itself is evidence of this compromise. The fontanelles, the soft spots on an infant's head where skull bones have not yet fused, are larger and persist longer in humans than in other primates. The anterior fontanelle, the diamond-shaped soft spot at the top of the head, doesn't fully close until 12 to 18 months after birth. This prolonged openness allows for continued rapid brain growth outside the womb and facilitates skull compression during birth. The sutures between skull bones in human infants are loose and flexible, allowing the bones to overlap during the passage through the birth canal. This molding can be extreme. Infants born after long labors often have dramatically elongated heads immediately after birth, a visible testament to the compression forces involved. The skull rounds out over days to weeks, but the temporary deformation shows how essential this flexibility is. Without it, the head simply would not fit. There's debate in the scientific community about whether to call this premature birth or simply the human developmental pattern. Some researchers argue that 9 months is the appropriate human gestation, and that helplessness at birth is a feature, not a bug. It allows for greater learning and cultural adaptation. During the postnatal developmental period, others maintain that it's clearly a compromise forced by anatomical constraints, and that the helplessness is a cost we pay, not a benefit we evolved for. The evidence seems to support the compromise interpretation. The extreme vulnerability of human infants creates enormous costs. Infant mortality in pre-modern populations was staggeringly high. Often 25 to 40% of infants died before age 5. Much of this was due to disease and malnutrition, but some was directly related to the infant's inability to survive without constant care. A human infant left alone for even a few hours will die of exposure, dehydration, or predation. No other primate infant is that vulnerable. This vulnerability in turn creates demands on the mother and the community. Human mothers cannot simply give birth and return to normal activities, as many mammals can. The infant requires constant holding, feeding every few hours, temperature regulation, and protection. This level of care is possible only with significant social support, which itself becomes an evolutionary factor we'll explore. later the premature birth solution represents the third major evolutionary compromise in the cascade toward dangerous human pregnancy. First, the pelvis narrowed for bipedalism, shrinking the birth canal. Second, the brain expanded for intelligence, enlarging the infant head. Third, birth timing shifted earlier to fit the large head through the narrow canal before it grew too large. This solved the size problem barely, but created new dangers around the process of birth itself. Because even with birth happening relatively early, even with the infant's skull capable of compression, the passage through the human birth canal is unlike any other in nature. The geometry of the journey itself holds dangers that no amount of developmental timing can eliminate. Asterisk even with infants born neurologically premature to keep head size manageable. The journey through the human pelvis became unlike any other birth in the natural world. The human birth canal is not a straight tube. It is a complex, three-dimensional pathway with changing dimensions and orientations. An infant must navigate this passage through a series of rotations, twists, and adjustments that are biomechanically unique to our species, in most mammals. The birth canal is relatively straight and consistent in shape. The pelvic inlet where the canal begins and the pelvic outlet where it ends are similar in dimension and orientation. The infant enters, passes through, and emerges without needing to change position. In primates like chimpanzees and gorillas, the canal is oval-shaped and spacious enough that the infant can pass without rotation. The human pelvis, reshaped by the demands of bipedalism, presents a different challenge. The pelvic inlet, at the top of the birth canal, is widest from side to side. Its longest diameter runs transversely across the body. The pelvic outlet, at the bottom, is widest from front to back. Its longest diameter runs anteroposteriorly, from the pubic bone to the tailbone. The midplane of the pelvis, the narrowest point along the passage, has yet another orientation. This means the infant must rotate as it descends. The journey typically unfolds like this. The infant begins labor in a transverse position, head entering the pelvic inlet sideways to align the longest diameter of the head with the longest diameter of the inlet. As labor progresses and the head descends, the infant encounters the midplane. Where the dimensions differ, the head must rotate usually about 90 degrees to navigate through. By the time the infant reaches the pelvic outlet, it has rotated again, ideally arriving in the occiput anterior position, face down, looking toward the mother's spine. This rotation is not voluntary. The infant is not conscious of movement, cannot control positioning, and is entirely passive in the process. The rotation occurs because of the complex interaction between uterine contractions, pushing the infant downward, the shape of the birth canal guiding and constraining movement, and the anatomy of the infant's skull and body responding to pressure and space. It's a biomechanical process, but one with significant room for error. When birth proceeds normally, the rotation happens instinctively, guided by millions of years of selection for infants whose skull and body proportions navigate the passage successfully. But the complexity of the required movements means there are many ways for the process to go wrong. The infant may fail to rotate fully, becoming stuck in an oblique or transverse position. This is called malposition, and it can cause obstructed labor. The infant's head may tilt incorrectly, presenting a wider diameter to the narrowest part of the canal. The shoulders may fail to follow the head's rotation, causing shoulder dystocia, where the head delivers, but the shoulders lodge behind the pubic bone. Comparative anatomy studies highlight just how unusual the human birth canal is. When researchers modeled the passage of a chimpanzee infant through a chimpanzee pelvis, the process is straightforward: enter, descend, exit. No rotation required. The infant's head is small enough relative to the canal that it simply passes through. When they model a human infant through a human pelvis, the simulation shows the complex corkscrew motion required for success. The direction the infant faces at delivery also sets humans apart. In most primates, infants are born facing forward toward the mother's front. This allows the mother to reach down, guide the infant out, clear its airway, and immediately bring it to her chest. She can see the infant's face, assess its condition, and assist if the umbilical cord is wrapped around the neck. Human infants, because of the rotation required by pelvic geometry, are usually born facing backward toward the mother's spine. This means the mother cannot see the infant's face during delivery. She cannot easily reach down to guide it. If she tries to pull the infant out herself, she must pull upward and over her pubic bone, a motion that risks injury to both infant and mother. The backward-facing birth position essentially makes unassisted human birth far more difficult and dangerous than in other primates. The mechanics of this passage also create risks for the infant. The compression forces on the skull during birth are immense. Studies measuring intrauterine pressure during contractions show forces exceeding 50 millimeters of mercury being exerted on the infant's head with each contraction over the course of labor, which can last 12, 18, 24 hours or more. For first-time mothers, the cumulative compression is substantial. While the skull is designed to withstand this through molding, excessive force or prolonged compression can cause complications: skull fractures, intracranial bleeding, nerve damage. The umbilical cord presents another hazard specific to the twisted pathway. As the infant rotates through the canal, the cord can become compressed between the infant's body and the walls of the pelvis, reducing blood and oxygen flow. Prolonged compression leads to fetal distress and potential brain damage. The cord can also wrap around the infant's neck during rotation. In many cases, this resolves without issue. The cord is long and flexible enough to accommodate the baby's movement. But if the cord is short or the wrapping is tight, it can constrict during delivery, becoming a life-threatening emergency. The posterior position facing the mother's spine is optimal, but not universal. Some infants arrive in the occiput posterior position, facing upward toward the mother's abdomen. This is often called sunny side up. This position makes delivery significantly more difficult because the infant's head does not flex properly, presenting a larger diameter to the pelvis. Labor is longer, more painful, and more likely to require intervention. Anthropological studies examining human populations across diverse geographies and genetic backgrounds find that while there is variation in pelvic shape, some populations tend toward rounder inlets. Others, more overall human populations, share the fundamental twisted geometry. that requires infant rotation. This is a universal human characteristic, not a feature of some populations. The obstetric challenge is built into the species. There's an elegant but harsh logic to this anatomy. Natural selection shaped the human pelvis to the maximum width, compatible with efficient bipedal walking. It shaped the infant's head to the minimum size compatible with brain development. The birth canal became a passage calibrated to the narrowest possible tolerances. The rotation required during birth is a solution that allows the largest possible head through the narrowest possible space, but it is a solution that operates at the edge of mechanical possibility. This creates the fourth compromise in the cascade. Birthing process complexity versus safety. A simple, straight birth canal would be safer, with fewer opportunities for malposition, obstruction, or cord compression. But a straight canal wide enough for a human infant's head would require a pelvis to wide for efficient walking. So we have a complex canal that fits, barely, but demands a choreographed series of movements that do not always occur correctly. And this complexity has another profound consequence. It makes solitary human birth extraordinarily dangerous. The backward-facing infant, the complex rotations, the inability of the mother to assist herself, all of these factors mean that human mothers evolved to need something no other primate requires: the presence of others during birth. Pause here and consider the journey we've traced through deep time. For distinct evolutionary adaptations, each solving a crucial survival problem, each creating reproductive danger, we stood upright and narrowed the pelvis. We expanded our brains and enlarged our heads. We shifted birth earlier to keep heads small enough to fit. We developed a twisted birth canal to maximize the match between head and pelvis. Each step seemed advantageous in isolation, yet together they constructed a system where birth became a trial. Unlike any other in the mammal world, if you're using this to fall asleep, you're exactly where you should be. The information continues, layering complexity, but the tone remains constant, calm, inevitable. For those still actively listening, you're beginning to see the pattern. Human reproduction is not dangerous because of a single flaw, but because of cascading compromises, each necessary, each costly. We're going to continue deeper now, into the social consequences of these anatomical changes, and then into the physiological dangers that anatomy alone cannot explain. Rest if you need to. The exploration continues. Unlike nearly every other mammal on Earth, human mothers evolved to need help during childbirth not as a cultural preference, but as an anatomical necessity. Across the animal kingdom, birth is typically a solitary event. Mammals in the wild seek privacy and isolation when labor begins. A pregnant cat finds a hidden corner. A deer moves away from the herd into dense brush. Elephants may have other females nearby, but the laboring mother typically delivers alone. Even among our closest primate relatives, solitary birth is the norm. Chimpanzee mothers in the wild retreat from their groups when labor begins, seeking seclusion in the trees. They give birth alone, without assistance, and return to the group with the newborn clinging to their chest. Gorillas follow similar patterns. Solitary birth makes evolutionary sense for most species. Birth is a time of vulnerability. The laboring animal is distracted, unable to flee quickly from predators. And the scent of blood and amniotic fluid can attract danger. Seclusion reduces risk. Additionally, in species where the mother can manage birth independently where the infant emerges facing forward, where she can clear airways and sever the cord herself, there is no survival advantage to having others present. Privacy is simply safer. Human birth breaks this pattern completely. In every known human culture, across all historical periods and geographic regions, birth is attended by others, typically experienced women mothers, grandmothers, aunts, midwives are present to assist. The laboring mother does not retreat to give birth alone. She is surrounded, supported, guided. This universality suggests that birth attendance is not merely a cultural practice, but a biological necessity encoded into human reproduction. The anatomical reasons become clear when we consider the mechanics we've already explored. The infant's backward-facing position means the mother cannot see or easily reach her own baby. During delivery, she cannot guide the head as it crowns, cannot clear the airways as the face emerges, cannot check if the umbilical cord is wrapped dangerously, if complications occur if the infant becomes stuck, if the cord is compressed. If the mother begins to hemorrhage, she cannot address these herself while in the midst of labor. An attendant changes everything. Another person can see what the mother cannot see. They can guide the infant's head, support the perineum to prevent tearing, clear the baby's mouth and nose immediately upon delivery, assess the infant's condition, manage the umbilical cord. If the infant's shoulders become stuck, the attendant can perform maneuvers to free them. If bleeding becomes excessive, they can apply pressure, massage the uterus, or assist with delivering the placenta. The attendant's presence transforms a potentially lethal situation into a manageable one. Studies of unattended human births rare in modern contexts, but documented in cases of surprise rapid labor or isolated situations show significantly higher rates of complications and mortality for both mother and infant compared to attended births. Even in populations without modern medical technology, the presence of a skilled birth attendant reduces risk substantially. The archaeological and anthropological evidence for birth attendants stretches back into prehistory. While we cannot directly observe ancient births, we can infer practices from skeletal evidence, burial patterns, and the universality of midwifery across all studied cultures. Midwifery, the practice of skilled assistance during childbirth, appears to be one of humanity's oldest professions, predating agriculture, metalworking, and written language. Ancient texts from Mesopotamia, Egypt, Greece, and China all reference midwives and birth attendants. Medical papyri from ancient Egypt describe birth practices and attendant roles. Classical Greek and Roman sources discuss midwifery as an established, respected practice. In societies without written records, oral traditions and anthropological observations confirm that specialized birth knowledge is transmitted from generation to generation, and that certain women become recognized experts in attending births. Asterisk. This social dimension of birth ties into a broader pattern in human evolution, cooperative breeding. Unlike most primates, where the mother alone cares for her offspring, humans are cooperative breeders. Infants are cared for not just by the mother, but by fathers, grandparents, siblings, and other community members. This sharing of childcare burden allows human mothers to have shorter intervals between births. A chimpanzee typically births every 5 to 6 years, while human hunter-gatherers often birth every 3 to 4 years. Birth attendance is the beginning of this cooperative pattern. The community invests in each birth because the survival of the infant benefits the group. In small-scale societies, every child represents future labor, defense, and reproductive capacity for the community. High infant and maternal mortality directly threatened group survival. Developing expertise in managing birth and ensuring that expertise was present at every delivery was a collective survival strategy. There's also evidence that birth attendance served psychological and educational functions. Women learned about birth by attending others' deliveries before experiencing their own. They absorbed knowledge about labor progression, coping strategies. What is normal and what signals danger? This transmission of knowledge across generations created a cultural repository of obstetric understanding that improved outcomes. The social nature of human birth also shaped maternal psychology. Unlike other mammals, human mothers in labor often seek company rather than solitude. They find comfort in the presence of trusted others. This is not universal. Some women prefer privacy, but the statistical pattern across cultures shows that most laboring women benefit from continuous support. Modern studies confirm this. Continuous labor support from a doula or trained companion reduces the length of labor, decreases the need for pain medication, lowers the rate of cesarean sections, and improves maternal satisfaction with the birth experience. But we must acknowledge the tension here as well. Social birth creates dependency. A human mother alone, without assistance, faces dramatically higher mortality risk. This is unique among primates. Our reproductive success became tied not just to individual physiology, but to social structures. A woman's ability to survive childbirth depended on her relationships, her community, the willingness of others to help. This made human reproduction a social act in a way it is not for most mammals. This represents the fifth evolutionary compromise: reproductive independence versus survival. Most mammals can reproduce successfully in isolation. Humans cannot. We traded self-sufficiency for the benefits of bipedalism, large brains, and social complexity. But the cost was that bringing new life into the world required the cooperation of others. Yet even with social support, even with skilled attendance, human mothers faced dangers that assistance alone could not prevent. The mechanical challenges of birth were only part of the story. Hidden within the maternal body was another danger, one that could not be seen or anticipated until it was too late. The way human pregnancy connects mother and child through the placenta creates vascular risks that social support cannot address. Asterisk beyond the mechanical challenges of fitting an infant through a narrow, twisted birth canal. Human mothers face a hidden danger embedded in the way our species nourishes the developing fetus. The placenta. The placenta is a temporary organ, existing only during pregnancy, that serves as the interface between maternal and fetal circulation. It is the lifeline, providing oxygen and nutrients to the developing child while removing waste products. All placental mammals, the taxonomic group including most mammals, possess this organ. But not all placentas are created equal. The structure, depth of implantation, and invasiveness of the placenta varies significantly across species. And humans possess one of the most aggressive, deeply invasive placentas in the animal kingdom. To understand the danger this creates, we must first understand placental types. Mammals are classified by how deeply the placenta invades the uterine wall. In epithelial placentation, seen in horses and pigs, the placenta sits against the uterine lining, but does not invade it. The barrier between maternal and fetal blood consists of multiple tissue layers. In endothelial placentation, seen in dogs and cats, the placenta erodes through some uterine tissue, but does not reach maternal blood vessels directly. The barrier is thinner. Humans, along with other primates and rodents, have hemorrhagic placentation. Hemo refers to blood. Chorial refers to the fetal chorion, part of the placental structure. In hemorrhagic placentation, the placenta invades deeply into the uterine wall, breaking down maternal blood vessels so that fetal tissue is bathed directly in maternal blood. There is no longer a thick barrier. Only a thin layer of cells separates maternal blood from fetal tissue. This allows for extremely efficient transfer of oxygen and nutrients essential for supporting the metabolic demands of the large, energy-hungry human fetal brain. But efficiency comes at a cost. The deep invasion of the placenta into the uterine wall creates two major dangers: hemorrhage during placental separation, and the potential for abnormally deep invasion. During pregnancy, the placenta is anchored to the uterine wall. Blood flow to the uterus increases dramatically by term. Approximately 500 to 800 milliliters of blood per minute flows through the uterine arteries to the placenta. This is an astonishing volume, representing a significant portion of the mother's cardiac output. After the infant is born, the placenta must separate from the uterine wall and be delivered. This is called the third stage of labor. In species with less invasive placentas, separation is relatively clean. The placenta peels away without significant bleeding because it was never deeply embedded. In humans, the separation site is a raw wound, with blood vessels that were supplying the placenta suddenly open and bleeding into the uterine cavity. If the uterus contracts properly, after delivery, a process called uterine involution, these vessels are compressed and sealed off, and bleeding is controlled. But if the uterus does not contract adequately, if the placenta does not separate completely, or if pieces of placenta remain attached, hemorrhage can be rapid and severe. Postpartum hemorrhage is clinically defined as blood loss exceeding 500 milliliters after vaginal birth, or 1,000 milliliters after cesarean delivery. Severe hemorrhage exceeding 1,000 milliliters can lead to shock, organ failure, and death within minutes to hours if not controlled. Throughout human history, before the advent of modern medical interventions, blood transfusions, surgical techniques, medications to contract the uterus, postpartum hemorrhage was one of the leading causes of maternal death. Archaeological evidence shows that maternal mortality was common in ancient populations. And when causes can be inferred from skeletal remains and burial contexts, hemorrhage is a likely culprit. Historical medical texts from ancient Greece, Rome, China, and Islamic civilizations describe postpartum bleeding and the limited interventions available. Manual compression of the uterus, herbal preparations to stimulate contractions, sometimes desperate attempts at packing the uterus to control bleeding. Success rates were poor. Even today, with modern medicine, postpartum hemorrhage remains a significant concern. It is one of the top 5 causes of maternal mortality worldwide, particularly in low-resource settings where blood transfusions and surgical interventions are not readily available. In developed countries with full medical resources, hemorrhage still accounts for a notable percentage of maternal deaths and near misses. Comparative data shows that humans lose more blood during delivery than most other mammals. Studies measuring postpartum blood loss across primate species find that humans experience higher average blood loss than chimpanzees or gorillas, even when accounting for body size differences. This is directly related to the invasiveness of the human placenta and the rich blood supply required to support the large fetal brain. Asterisk. The second major danger related to placental invasion is abnormal placentation. In some pregnancies, the placenta invades too deeply, a condition called placenta accreta. In its most severe forms, placenta increta and placenta praecreta, the placenta grows through the uterine wall and into surrounding organs, such as the bladder. When this occurs, the placenta cannot separate normally after delivery. Attempting to remove it causes catastrophic hemorrhage. The only definitive treatment in severe cases is hysterectomy, surgical removal of the uterus. Placenta accreta is more common in women who have had previous cesarean sections, because scar tissue in the uterine wall provides an easier pathway for abnormal placental invasion. With rising cesarean rates globally, placenta accreta is becoming more frequent, creating a modern obstetric crisis rooted in ancient biology. There's also the risk of placental abruption, where the placenta separates from the uterine wall prematurely before the infant is born. This can cause massive internal bleeding, endangering both mother and fetus. Abruption is more common in humans than in other primates, again linked to the deep, invasive nature of our placental structure. The evolutionary logic here is clear but harsh. The human fetal brain requires extraordinary amounts of energy and oxygen. The hemorrhagic placenta, with its direct access to maternal blood, provides this efficiently. Natural selection favored placentas that could support large brains. But the deeper the invasion, the greater the hemorrhage risk during separation. The placenta that enables our intelligence is also the placenta that can kill the mother. This is the 6th evolutionary compromise: fetal nutrition versus maternal safety. The same organ that makes human brain development possible creates one of the most lethal moments. In human reproduction, the minutes and hours after birth, when the placenta must separate and the uterus must contract to seal off blood vessels. For most of human history, this moment was survived by most women, but not all. And for those who did not survive, bleeding to death after successfully delivering a living child. The evolutionary trade-off was complete. Yet hemorrhage is only one dimension of the physiological stress human pregnancy places on the maternal body. The metabolic demands of carrying a human infant to term push the female body to extremes that are, once again, unusual among mammals. The energy required, the cardiovascular strain, the biochemical changes, all of these amplify the danger inherent in human reproduction. Asterisk. Carrying a human infant to term pushes the maternal body to physiological limits that exceed those seen in nearly all other primates, creating systemic stress that, even without complications during birth, can threaten maternal life. Pregnancy is, at its core, a metabolic challenge. The mother's body must provide all energy, nutrients, oxygen, and building materials for a rapidly growing organism, while simultaneously maintaining her own physiological functions. In humans, this challenge is amplified by the size and developmental demands of the fetus, particularly the brain, and by the length of gestation. Human pregnancy lasts approximately 40 weeks, or to 180 days from the last menstrual period. This is one of the longer gestation periods among primates relative to body size. A chimpanzee pregnancy lasts about 237 days. A gorilla pregnancy averages to 155 days. While humans are not the longest in absolute terms, elephants gestate for 22 months relative to body size and metabolic rate. Human pregnancy represents a substantial investment. The caloric demands increase progressively through pregnancy. In the first trimester, energy requirements are only slightly elevated. By the third trimester, a pregnant woman requires an additional 300 to 500 calories per day beyond her baseline needs. This may seem modest, but over the full 9 months, the cumulative energy cost is significant, particularly in populations where food is scarce or nutritionally limited. The cardiovascular system undergoes dramatic changes. Blood volume increases by 40 to 50% to support the placenta and the growing fetus. Cardiac output, the amount of blood the heart pumps per minute, increases by 30 to 50%. The heart works harder, pumping more blood with each beat. Blood pressure typically decreases slightly in the second trimester due to hormonal changes that relax blood vessels, then returns to baseline by term. For women with underlying cardiovascular conditions, these changes can trigger heart failure. The respiratory system is also stressed. The growing uterus pushes upward against the diaphragm, reducing lung capacity. Oxygen demand increases because the fetus requires a constant oxygen supply via the placenta. Pregnant women breathe more frequently and more deeply to compensate. Women with asthma or other respiratory conditions often experience worsening symptoms during pregnancy. Metabolic. Pregnancy induces a state of insulin resistance, particularly in the third trimester. This means the mother's cells become less responsive to insulin, the hormone that regulates blood glucose. The purpose is adaptive. By making the mother slightly insulin resistant, more glucose remains in the bloodstream, available to cross the placenta and nourish the fetus. However, in some women, this insulin resistance becomes excessive, leading to gestational diabetes, abnormally high blood sugar during pregnancy. Gestational diabetes affects approximately 5 to 10% of pregnancies and creates risks for both mother and baby, including excessively large infants, birth complications, and long-term metabolic problems for the mother. The skeletal system also pays a price. The developing fetal skeleton requires large amounts of calcium and phosphorus. If dietary intake is insufficient, the maternal body will leach calcium from the mother's bones to supply the fetus. Over multiple pregnancies, this can lead to decreased bone density and increased fracture risk in the mother. Teeth can also be affected. There's a historical saying, "Gain a child, lose a tooth," reflecting the reality that calcium depletion during pregnancy can weaken dental enamel. The immune system undergoes a paradoxical shift. Normally, the immune system attacks foreign tissue. This is why organ transplants require immunosuppressive drugs. The fetuses, genetically half foreign, carrying the father's genes. To prevent the maternal immune system from rejecting the fetus, the body enters a state of partial immune suppression during pregnancy. This protects the fetus but leaves the mother more vulnerable to infections. Diseases that a non-pregnant woman might fight off easily can become severe during pregnancy. The renal system is strained as well. The kidneys must filter not only the mother's waste products, but also those of the fetus, which are transferred across the placenta into the mother's bloodstream. Kidney filtration rate increases significantly. The ureters, tubes carrying urine from the kidneys to the bladder, dilate and become more prone to infections. Urinary tract infections are common during pregnancy and, if untreated, can progress to kidney infections, posing serious risks. Hormonal changes are profound. Progesterone, the primary pregnancy hormone, rises to levels hundreds of times higher than non-pregnant levels. Estrogen increases dramatically as well. These hormones maintain the pregnancy, relax the uterine muscle to prevent premature contractions, and prepare the body for birth and breastfeeding. But they also have side effects: nausea, vomiting, mood changes, skin changes, and alterations in ligament laxity that can cause joint pain and instability. The blood itself changes composition. Pregnant women become relatively anemic. The blood volume increases more than the red blood cell count, diluting the blood. This is called physiological anemia of pregnancy. If the mother's iron stores are low, true anemia develops, causing fatigue, weakness, and increased cardiovascular strain. Clotting factors in the blood increase, making pregnant women more prone to blood clots. This is an adaptive change, preparing the body to minimize hemorrhage during delivery. But it also increases the risk of dangerous clots in the legs or lungs. Preeclampsia is one of the most dangerous pregnancy complications, affecting approximately 5 to 8% of pregnancies worldwide. It is characterized by high blood pressure and protein in the urine, typically appearing after 20 weeks of gestation. The underlying cause involves dysfunction of the placenta and maternal blood vessels. In severe cases, preeclampsia progresses to eclampsia, where the mother has seizures or HELLP syndrome, a life-threatening condition involving hemolysis, breakdown of red blood cells, elevated liver enzymes, and low platelet count. Before modern medicine, preeclampsia and eclampsia were major causes of maternal death. Even today, they remain significant dangers, particularly in areas without access to blood pressure. Monitoring and emergency obstetric care, comparative studies across primates. show that humans experience a higher rate of pregnancy-related, metabolic and cardiovascular complications than chimpanzees or other great apes. While data on wild primate pregnancies is limited, captive primate studies and the available evidence suggest that conditions like preeclampsia are rare or absent in other primates. This points to something uniquely demanding about human pregnancy. The evolutionary explanation returns to the brain. The human fetal brain's growth rate in the third trimester is extraordinary. It nearly triples in weight between 20 weeks and term. This growth requires immense resources: fatty acids for myelin, glucose for energy, amino acids for proteins, micronutrients for enzyme systems. The placenta must deliver all of this, drawing on maternal reserves. If those reserves are insufficient, fetal brain development can be compromised, affecting lifelong cognitive outcomes. Natural selection favored placentas and maternal physiology that prioritized fetal brain development, even at significant cost to maternal health. This is the seventh evolutionary compromise: fetal developmental time versus maternal physiological capacity. The 9 months of human pregnancy represent the maximum duration that the maternal body can sustain the fetus before the metabolic burden becomes unsustainable. Carrying the pregnancy longer would allow for greater neurological maturity at birth, but the mother's body cannot support it. Birth happens at 9 months not because it's optimal for the infant, but because it's the limit of what the mother can endure. Asterisk. Historical populations faced these metabolic challenges without modern nutrition. Diets were often insufficient in calories, protein, iron, calcium, and vitamins. Pregnant women in agricultural and pre-agricultural societies frequently did not have access to the supplemental nutrition needed to support both their own health and fetal growth. Malnutrition amplified all the risks we've discussed. It increased the likelihood of small maternal pelvis if the mother herself was malnourished in childhood, increased the risk of anemia and hemorrhage, weakened the immune system, and impaired the body's ability to repair after birth, even in modern populations with abundant food. Pregnancy-related metabolic complications persist. Obesity, now common in many countries, creates its own set of risks: gestational diabetes, preeclampsia, and complications during delivery. The maternal body is adapted to handle pregnancy under conditions of moderate nutrition, but it struggles at both extremes: too little and too much. The metabolic burden of pregnancy intersects with all the other dangers we've explored. A mother weakened by malnutrition is less able to endure a long, difficult labor. A mother with gestational diabetes is more likely to have an excessively large infant, worsening cephalopelvic disproportion. A mother with preeclampsia is at higher risk for placental abruption and hemorrhage. The dangers compound, and layered on top of these predictable metabolic stresses is another factor that makes human reproduction uniquely unpredictable: the extraordinary genetic variability within our species, which means that no two pregnancies are identical, and outcomes can vary wildly even among closely related individuals. Asterisk. We've now journeyed through 7 distinct evolutionary compromises, each one solving a survival problem while creating reproductive danger. Notice how they interconnect and amplify each other. Bipedalism narrowed the pelvis, forcing premature birth and a twisted birth canal. Brain expansion increased fetal size and metabolic demands. Deep placental invasion enabled brain growth but created hemorrhage risk. Metabolic stress pushed maternal physiology to its limits. These are not separate problems, but cascading consequences, each emerging from the last. For those still actively listening, you're tracking a pattern that reveals why modern obstetrics exists at all. Because human birth is a system operating at the edge of what biology can sustain. For those drifting towards sleep, the information continues in the same measured rhythm, building understanding that persists whether you're awake or not. We're moving now into the genetic and historical dimensions of this danger, exploring how variability makes prediction impossible and how, for most of human history, pregnancy was the most dangerous event in a woman's life. Unlike species with relatively uniform and predictable births, human reproduction carries an extraordinary degree of genetic variability, creating a final layer of unpredictability and danger that no amount of social support or maternal health can fully eliminate. Genetic diversity is generally an evolutionary advantage. A genetically diverse population can adapt to changing environments, resist diseases, and maintain fertility across a range of conditions. Humans are, in some ways, less genetically diverse than we might expect. Our species went through several population bottlenecks, periods when human numbers dropped dramatically, reducing genetic variation. Yet in the specific domains that affect reproduction pelvic dimensions, fetal size, placental function, blood chemistry, there remains substantial variability. And this variability creates unpredictability. Pelvic size and shape vary significantly among women, influenced by genetics, nutrition during childhood, and developmental factors. Some women have wider, more spacious pelvises. Others have narrower ones. The shape of the pelvis also varies. Anthropologists classify pelvic types into categories like gynecoid, android, anthropoid, and platypeloid, each with different dimensions and implications for birth. These variations are partly heritable, meaning daughters may inherit pelvic dimensions similar to their mothers. But the inheritance is not deterministic. A mother with a narrow pelvis may have a daughter with a wider one, and vice versa. Fetal size also varies widely. Newborn weight in humans typically ranges from about 500 grams, 5.5 pounds, to 4,500 grams, 10 pounds in full-term infants, with significant variation even within families. Factors influencing fetal size include genetics from both parents, maternal nutrition, placental efficiency, gestational diabetes, and the sex of the infant. Boys tend to be slightly larger on average. Head circumference. The critical dimension for birth also varies, though less dramatically than body weight. The interaction between pelvic size and fetal size determines whether a particular birth will be mechanically feasible. A woman with a relatively small pelvis and a relatively large infant faces cephalopelvic disproportion. The head simply does not fit. But the same woman carrying a smaller infant, or a woman with a larger pelvis carrying the same large infant, might have no mechanical difficulty at all. The outcome is a matter of specific pairings, influenced by genetic lottery. This variability means that a woman cannot predict, based on her own mother's birth experiences or her sister's experiences, what her own birth will be like. Even her own subsequent births can differ dramatically. A woman who delivered a first child vaginally without difficulty might face obstruction with a second, larger child. The unpredictability is inherent to the system. Blood type incompatibility adds another layer of genetic risk. In Rh incompatibility, a mother with Rh-negative blood lacking a specific protein on red blood cells carries an Rh-positive fetus inheriting the Rh gene from the father. If fetal blood cells cross the placenta into maternal circulation, the mother's immune system can produce antibodies against the Rh protein. In subsequent pregnancies with Rh-positive fetuses, those antibodies can attack fetal red blood cells, causing hemolytic disease of the newborn, which can be severe or fatal. Before the development of Rh immunoglobulin rogum in the 1960s, which prevents antibody formation, her incompatibility was a significant cause of fetal and newborn death. ABO blood type incompatibility is more common, but usually less severe. If a mother has type O blood and the fetus has type A or B inherited from the father, maternal antibodies against A or B antigens can cross the placenta and cause mild hemolysis in the fetus. In most cases, this is manageable, but in rare instances, it can cause significant jaundice and require treatment. Genetic disorders also introduce unpredictability. Some genetic conditions are incompatible with life, causing miscarriage before the pregnancy is recognized. Others cause developmental abnormalities that complicate birth or affect fetal viability. Neural tube defects like spina bifida, heart malformations, chromosomal abnormalities like Down syndrome, all of these occur with varying frequencies and can affect pregnancy outcomes. While many genetic conditions occur randomly through new mutations, others are inherited in patterns that are difficult for families to anticipate without genetic. Testing uterine anatomy varies as well. Some women have uterine malformations, a bicornuate heart-shaped uterus, a septate uterus with a partition dividing the cavity, or a unicornuate uterus with only one functional side. These variations can affect how the fetus positions itself, increasing the likelihood of breech or transverse presentations that complicate delivery. They can also increase the risk of preterm birth. Placental implantation is partly a matter of chance. The placenta may implant high on the uterine wall, low near the cervix placenta previa, which can block the birth canal, or over an old cesarean scar, increasing risk of accreta. The efficiency of the placenta also varies. Some placentas are highly effective at nutrient transfer, supporting robust fetal growth, while others are less efficient, leading to growth restriction. Hormonal responses to pregnancy vary among women. Some women experience severe nausea and vomiting hyperemesis gravidarum due to heightened sensitivity to pregnancy hormones. Others have minimal symptoms. Some women develop gestational diabetes due to genetic predispositions affecting insulin function. Others do not. Preeclampsia risk is influenced by genetic factors, with women whose mothers or sisters had preeclampsia facing higher risk. Though the genetic mechanisms are complex and not fully understood, anthropological studies examining pregnancy outcomes across different populations find variation in complication rates. Some of this variation is environmental nutrition, disease burden, access to care, but some appears to be genetic. Certain populations have higher rates of gestational diabetes, others higher rates of preeclampsia, still others different average birth weights. These patterns suggest that genetic background influences pregnancy risk, though the specific genes involved are still being identified through ongoing research. There's an evolutionary paradox here. Genetic diversity provides adaptability, but in the context of reproduction, it creates unpredictability that increases risk. A species with more uniform genetics would have more predictable birth outcomes, all mothers, and infants roughly the same size and shape, all births following a similar pattern. But such uniformity would make the species vulnerable to diseases, environmental changes, and other selective pressures. Humans chose, in an evolutionary sense, diversity and adaptability over reproductive predictability. This is the eighth and final evolutionary compromise: genetic diversity and adaptability versus reproductive predictability and safety. The same variability that allows humans to thrive in environments, from Arctic tundra to tropical rainforests, to resist a wide array of pathogens, to adapt behaviorally and physiologically to novel challenges. This variability also means that each pregnancy is a unique experiment, with outcomes that cannot be guaranteed. Medical screening attempts to reduce this unpredictability. Ultrasound allows visualization of the fetus, measuring head size and estimating weight. Blood tests screen for genetic disorders, gestational diabetes, Rh incompatibility. Pelvimetry, measuring the maternal pelvis, was once common, but is now rarely done because the measurements have limited predictive value. Birth is so complex that static measurements cannot reliably predict dynamic outcomes. Yet even with all modern screening, unexpected complications arise. Some infants are larger or positioned differently than anticipated. Some placentas function less effectively than predicted. Some mothers develop preeclampsia suddenly, without warning signs. The genetic lottery means that even optimal conditions are healthy. Well-nourished mother, access to prenatal care, skilled attendants cannot eliminate risk. The system is simply too variable. Natural selection has shaped human reproduction to work most of the time, but not all the time. The margin for error exists, but it is not wide for most of human history. This genetic unpredictability intersected with all the other dangers: narrow pelvis, large head, twisted birth canal, social dependence, hemorrhage risk, metabolic stress, and the result was a level of maternal mortality that, by modern standards, is staggering. The historical toll of human reproduction is the subject we turn to now, examining how these evolutionary compromises translated into lived and died experience across 300,000 years of Homo sapiens existence. Asterisk. For 300,000 years of Homo sapiens existence, and for millions of years before that across our hominin ancestors. The evolutionary dangers we have traced through deep time, translated into a staggering toll in human lives. Pregnancy and childbirth were, for most of human history, the leading causes of death for women of reproductive age. Estimating maternal mortality in prehistory is challenging. Soft tissue does not fossilize, and causes of death rarely leave clear skeletal markers. But anthropologists can make inferences from several lines of evidence. Age at death distributions in skeletal populations. The frequency of pelvic damage consistent with obstructed labor. Burial contexts that include mothers and infants together. And comparative data from historical populations where records begin to appear. Current estimates suggest that maternal mortality in pre-modern populations, those without access to surgical intervention, blood transfusion, antibiotics, or other modern obstetric care ranged from 1 to 2% per birth. This means that for every 100 births, 1 or 2 mothers died from pregnancy-related causes. At first glance, this may not seem catastrophic, but context matters. Women in pre-modern populations typically experienced multiple pregnancies over their lifetimes. In hunter-gatherer societies, average fertility was approximately 4 to 6 live births per woman, spaced 3 to 4 years apart due to extended breastfeeding, which suppresses ovulation. In agricultural societies, where breastfeeding patterns changed and food availability increased, fertility often rose to 6 to 10 births per woman. Each pregnancy carried that 1 to 2% mortality risk. Cumulative risk is calculated by compounding the per-birth risk over multiple pregnancies. A woman facing 6 births with a 1.5% risk per birth has roughly a 9% cumulative risk of dying from pregnancy-related causes over her reproductive lifetime. A woman facing 10 births faces approximately a 15% cumulative risk. These are not small numbers. They mean that in a community of 100 women, 9 to 15 would die from pregnancy or childbirth complications over the course of their lives. Historical records from Europe, Asia, and the Middle East, once writing systems and record-keeping emerged, confirm these estimates. Parish records from medieval and early modern Europe show maternal mortality ratios of 1,000 to 1,500 per 100,000. Live births equivalent to 1 to 1.5% per birth, with higher ratios in urban areas, where infectious diseases were more common. Hospital records from the 18th and early 19th centuries, before the advent of antiseptic practices, show even higher mortality rates, sometimes exceeding 5%. Because hospital births at that time were often associated with puerperal fever, a bacterial infection spread by unwashed hands of attendants, moving from patient to patient. Royal families, despite access to the best available care and nutrition, were not spared. Historical records of European royalty document numerous deaths of queens and princesses in childbirth. Catherine Parr, the 6th wife of Henry VIII of England, died from puerperal fever days after giving birth. Jane Seymour, Henry's 3rd wife, died 12 days after delivering the future Edward VI, likely from infection or hemorrhage. These women had the best midwives, the most comfortable conditions, and yet they died. Their deaths illustrate that, before modern medicine, social status provided no protection against the biological dangers of birth. The skeletal record adds another dimension. Paleopathologists studying ancient remains sometimes find evidence of trauma, consistent with obstructed labor, Pelvic fractures. Pubic symphysis damage the joint at the front of the pelvis that can separate under extreme strain, and occasionally even signs of fetal remains still lodged within the pelvic canal, indicating that the mother died before delivery could be completed. These findings are rare, not because obstructed labor was rare, but because most deaths from obstetric causes leave no skeletal markers: hemorrhage, infection, eclampsia, amniotic fluid embolism. None of these are visible in bones. Burial practices across many ancient cultures include instances of mothers buried with infants. Sometimes the infant is positioned at the mother's abdomen, suggesting death during or immediately after childbirth. These burials are found across continents and time periods: Neolithic Europe, ancient Egypt, pre-Columbian Americas, ancient China, indicating that maternal and infant death together was a common enough occurrence to be culturally recognized and ritually addressed. Asterisk. The major causes of maternal death in historical populations were hemorrhage, infection, obstructed labor, and eclampsia. Hemorrhage, as we've discussed, results from the placenta's invasive implantation and the high blood flow to the uterus. Without modern interventions, intravenous fluids, blood transfusions, medications to contract the uterus, surgical repair, severe hemorrhage progresses to shock and death within hours. Infection, particularly puerperal fever caused by bacteria entering the uterus during or after birth, killed countless women. Before the germ theory of disease and the practice of hand washing, infections were often introduced by attendants themselves. The risk increased in settings where multiple women gave birth in proximity, such as hospitals or lying in homes. Ignaz Semmelweis, a Hungarian physician in the 1840s, famously demonstrated that hand washing with chlorinated lime reduced puerperal fever deaths dramatically. But his ideas were initially rejected and not widely adopted until decades later, after Louis Pasteur's work on microbiology provided a theoretical framework: obstructed labor, where the infant cannot pass through the birth canal due to cephalopelvic disproportion, malposition, or other mechanical difficulties, can last for days. Prolonged labor exhausts the mother, causes tissue damage, and can lead to fistula tear between the vagina and bladder or rectum, causing permanent incontinence. If the obstruction is not resolved, both mother and infant die. Historical interventions for obstructed labor were brutal and often ineffective. Attempts to manually force the infant through, the use of instruments like forceps introduced in the 17th century, often causing injury, and in desperate cases, embryotomy, the dismemberment of the fetus to extract it piece by piece to save the mother's life. Asterisk. Eclampsia seizures caused by preeclampsia was poorly understood until the 20th century and had no effective treatment. Women who developed eclampsia often died from the seizures themselves, from stroke, or from related complications. Even today, eclampsia is managed, not cured. The only definitive treatment is delivery of the infant, which ends the pregnancy and resolves the condition. Cultural and religious practices evolved in response to these dangers. Many societies developed prayers, rituals, and protective amulets for pregnant women and those in labor. Deities associated with childbirth: Artemis in ancient Greece, Tauret in ancient Egypt, Bixia in China received offerings and supplications. Women prepared for the possibility of death during childbirth, sometimes writing wills or leaving instructions before labor began. The dangers were not abstract. They were lived reality, shaping women's expectations and communities' responses. Infant mortality compounded the tragedy, even when mothers survived. Approximately 25 to 40% of infants died before reaching age 5 in pre-modern populations. Many of these deaths occurred in the first days or weeks of life, from birth injuries, infections, congenital abnormalities, or prematurity. The human reproductive system, despite 300,000 years of natural selection, still failed frequently. Mothers who survived dangerous births often lost the infants. They had risked their lives to deliver. Demographic modeling based on historical and anthropological data suggests that maternal mortality had significant impacts on population structure and life expectancy. Life expectancy at birth in pre-modern populations was often 30 to 40 years, dragged down by high infant and child mortality. But even looking at life expectancy at age 15 essentially, how long someone who survived childhood could expect to live, women of reproductive age had higher mortality than men in the same age group, largely due to pregnancy-related deaths. This gap disappeared after menopause, when women's life expectancy equaled or exceeded men's. The evolutionary implications are profound. Maternal mortality represents a massive selection pressure. Women who died in childbirth did not raise existing children or have additional children, removing their genes and, critically, their mates' genes from future generations. One might expect that over hundreds of thousands of years, natural selection would have solved the obstetric dilemma, widening pelvises, shrinking heads, or altering birth timing to reduce mortality. But selection is constrained by trade-offs. Wider pelvises compromise bipedal efficiency, which affects survival in other domains' ability to walk long distances, flee predators, hunt, migrate. Smaller heads mean smaller brains, which reduce cognitive abilities that are crucial for human survival. Tool use, social cooperation, language. Earlier birth would mean even more premature, vulnerable infants, increasing infant mortality. Natural selection cannot optimize one trait without considering impacts on others. The human reproductive system, then, is not poorly designed. It is the best compromise that evolution could achieve. Given the conflicting demands of bipedalism, large brains, and live birth, the 1 to 2% maternal mortality rate represents the equilibrium point, where the benefits of our adaptation's intelligence, upright walking, social complexity outweigh the costs. It is a harsh equilibrium, measured in the lives of mothers, but it is one that allowed our species not just to survive, but to spread across the globe and become the dominant species on the planet. The 20th century brought a revolution. The development of antibiotics in the 1940s dramatically reduced infection deaths. Blood transfusions became routine, saving women from hemorrhage. Cesarean section, once a last resort procedure with high mortality, became safe and widely available. Prenatal care, including blood pressure monitoring and treatment of preeclampsia, allowed early detection and intervention. Maternal mortality in developed countries dropped by approximately 99% between 1900 and 2000. In countries with full access to modern obstetric care, maternal mortality ratios are now around 10 to 20 per 100,000 live births, 1 to 0.02% per birther. 50-fold reduction from historical levels, yet the danger is not eliminated. Even in the best resourced settings, women still die from pregnancy complications. Hemorrhage, amniotic fluid embolism, severe preeclampsia, and other conditions can be sudden and unpredictable. And globally, maternal mortality remains high in low-resource settings. Sub-Saharan Africa has maternal mortality ratios of 400 to 1,000 per 100. 0 live births in some countries back to pre-modern levels. The disparities highlight how much of modern maternal safety depends on medical infrastructure, trained personnel, surgical facilities, blood banks, medications. The historical toll of human pregnancy is not ancient history. It persists today in parts of the world without access to the medical advances that transformed birth from a life-threatening event into a generally safe one. Understanding the evolutionary roots of this danger, why human pregnancy became more dangerous than any other species, helps us appreciate both the magnitude of the historical burden and the marvel of modern medicine's ability to mitigate it. Consider the full journey we've traced together. Upright walking 6 million years ago, narrowing the pelvis, brain expansion over to million years, enlarging infant heads, premature birth to fit those heads through, creating helpless infants, a twisted birth canal requiring complex rotation, social dependence because mothers couldn't assist themselves, invasive placentation creating hemorrhage risks, metabolic extremes pushing maternal bodies to their limits, genetic variability making each birth unpredictable, and through it all, 300,000 years of human existence where 1 to 2% of mothers died with each birth. Each chapter has built on the last, revealing not a single flaw, but a cascading system of compromises. If you've drifted in and out of sleep, these ideas have layered into your understanding regardless. The threads come together now in a conclusion that makes sense of the paradox we began with. Why the most intelligent species on Earth has the most dangerous birth. Rest if you need to. The final synthesis is just ahead. We opened this exploration with a paradox. Humans are the most intelligent species on Earth. Yet we possess one of the most dangerous reproductive systems in the animal kingdom. The question we asked was why? What happened in our evolutionary journey to make creating life so perilous? The answer, as we have seen, is not simple. There is no single cause, no isolated evolutionary mistake. Human pregnancy became dangerous through a cascade of adaptations, each one solving a critical survival problem, each one creating reproductive risk. 6 million years ago, our ancestors stood upright. Bipedalism freed our hands, improved our vision across open landscapes, and made us more energy-efficient travelers. But it required a narrow pelvis, and a narrow pelvis meant a narrow birth canal. That was the first compromise. Mobility gained, easy birth lost. 2 million years ago, our brains began to expand at an unprecedented rate in the history of life. Intelligence brought tool use, language, social complexity, and the ability to adapt to any environment on Earth. But larger brains meant larger infant heads, and those heads had to pass through the already narrowed birth canal. That was the second compromise: cognitive power gained. Birth difficulty increased. To resolve the physical impossibility of fitting large heads through narrow pelvises, evolution shifted birth timing earlier. Human infants are born neurologically immature, helpless, requiring years of intensive care. That was the third compromise. Birth became survivable, but infants became utterly dependent. Even with premature birth, the passage through the human pelvis required a twisted, rotating journey unlike any other mammal. The complexity of this path created opportunities for malposition, obstruction, and complication. That was the fourth compromise: biomechanical efficiency maximized. But navigational complexity increased. The backward-facing birth position meant mothers could not assist themselves. Human birth became a social event, requiring the presence and skill of others. That was the fifth compromise. We gained communal support, but lost reproductive independence. The human placenta invaded deeply into the uterine wall to supply the enormous energy and nutrient demands of the developing brain. But deep invasion created hemorrhage risks when the placenta separated after birth. That was the sixth compromise: fetal nutrition maximized. Maternal safety reduced. Pregnancy pushed the maternal body to metabolic extremes: cardiovascular, respiratory, renal, endocrine. Immune systems all stressed by the demands of growing a large-brained infant. That was the seventh compromise: fetal development supported. But maternal physiology strained to its limits. Genetic variability gave humans adaptability and resilience across environments, but also made each pregnancy unpredictable, with outcomes depending on the specific pairing of maternal and fetal traits. That was the eighth compromise: diversity and adaptability gained, predictability and uniformity lost. These 8 compromises, layered across millions of years, transformed human reproduction into a system operating at the edge of biological possibility. For 300,000 years of modern human existence, the result was clear: maternal mortality of 1 to 2% per birth, cumulative lifetime risks of 10 to 20%, and the reality that pregnancy was a leading cause of death for women in their reproductive years. Natural selection did not fail. It made the best of an impossible situation. The human body, including the female reproductive system, is not badly designed, it is brilliantly compromised. Every feature we have explored reflects the tension between competing adaptive pressures. Evolution cannot optimize for only one function. It must balance trade-offs. And the balance it struck between walking and birthing, between intelligence and safety, between nutrition and hemorrhage risk allowed humans not merely to survive, but to thrive and spread across the planet. Asterisk. What we don't fully know, even now, is whether human anatomy is still evolving. Modern medicine has removed some of the selection pressure against difficult births. Women who would have died in previous centuries now survive and reproduce. Cesarean sections allow infants who could not fit through the birth canal to be delivered safely. Does this mean that human pelvises may narrow further, or infant heads grow larger? In future generations, it's possible, Though evolution is slow, and modern reproductive patterns delayed childbirth, smaller family sizes may influence selection in ways that are difficult to predict. We also don't know what the long-term effects of medical intervention will be. Humans are the only species deliberately bypassing natural selection. In reproduction on a large scale, this is ethically desirable. No one argues that women should die to maintain selection pressure, but it does mean that future human anatomy may diverge from the path that natural selection alone would have taken. There is a strange, quiet beauty in understanding these uncertainties. We cannot know what ancient human mothers felt, feared, or understood about the risks they faced. We cannot know how many potential genetic lineages ended because a pelvis was too narrow or a head too large. We cannot predict precisely where human evolution will go next, but we can honor the fact that every person alive today is descended from a line of women who survived. Every one of us exists because our maternal ancestors navigated these dangers successfully, often multiple times across hundreds of generations. Modern obstetrics, with all its technology and expertise, is built on a foundation of acknowledging these ancient realities. Prenatal care monitors for the complications that have killed mothers for millennia. Cesarean sections bypass the anatomical impasse that natural selection could never fully solve. Blood transfusions counter the hemorrhage risk inherent in deep placental invasion. We have not changed human biology, but we have surrounded it with medical scaffolding that drastically reduces mortality. The 99% reduction in maternal mortality in the past century is one of medicine's greatest achievements, yet it is still incomplete. Globally, hundreds of thousands of women still die each year from pregnancy-related causes, nearly all in settings where medical intervention is unavailable. The evolutionary dangers persist. The biological realities have not changed. Only access to resources has changed, and it has not changed everywhere. Understanding why human pregnancy became more dangerous than any other species is not an academic exercise. It is a window into what it means to be human, to carry the consequences of ancient adaptations in our bones and blood, to live in bodies shaped by trade-offs made millions of years before we existed. It is recognition that our intelligence, the trait we celebrate most, came at a cost paid by generations of mothers. It is appreciation for the fragility and resilience that coexist in human reproduction. If this journey through deep time has helped you think, learn, or rest, then it has served its purpose. The subjects I explore are meant to be companions for active minds seeking understanding, or for tired ones seeking the calm rhythm of narration. There are other stories like this, other threads of human history and biology waiting to be traced. Whenever you're ready, for now, consider this. You exist because of an unbroken chain of births that, against all the odds we've explored tonight, succeeded. Your presence is evidence of survival, of compromise, of bodies and lives given to the creation of the next generation. The danger was real, the cost was high, but somehow, despite the narrowed pelvis, the enlarged brain, the invasive placenta, the metabolic strain, the genetic lottery, the twisted path, and the historical toll, somehow, we made it through. Rest well, knowing that your existence is not just biology, but a testament to endurance across deep time. Thank you for journeying through this story with me. Sleep well, or wake refreshed, and carry forward the quiet marvel of understanding why we are the way we are.